Alrighty, so here are our objectives. So our goal is to better understand both normal gait and pathologic gait in MS, and identify some potential causes. And then from there, we're going to discuss some opportunities for assistive device prescription. So to begin, we're going to start with an overview of typical gait in order to build a better understanding of gait dysfunction in MS. This review is going to be rather limited and is more intended to put us in the appropriate mindset than be an all-inclusive review. Given that, I do encourage everyone to stand up and get moving as we go through this part. It's only going to be about 5 minutes, and then Lauren is going to graciously demonstrate as well, but I do encourage everyone to get up and get moving so this can help you learn a little better. So don't be afraid, go ahead. Yeah. All right. Thank you. All right, so grossly there are 3 main stages of gait. Weight acceptance, which is when the limb's making contact with the ground. Double limb support, or single limb support, which occurs when your opposing limb is going through swing phase. And swing phase, which occurs as our limb moves through the air. The first stage of gait we're going to start with is initial contact. And this is the moment where your limb is first touching the ground. In typical gait, your hip should be flexed to approximately 20 degrees, and your knee is going to be in slight flexion. And the ankle is in a neutral position here. Muscles of your legs that help for stability in this phase include the hip extensors, quads, anterior tibial muscles, and toe extensors. Next, we transition to loading response. And in this phase, our knee is going to undergo increased flexion to approximately 15 degrees. A foot flat position is achieved, meaning our ankle is going from neutral to about 5 degrees of plantar flexion via eccentric anterior tib control. Our muscles work for both stability and mobility purposes in this phase, and these muscles include primarily the hip extensors and abductors, eccentric quad control, and eccentric anterior tib control. Next, we transition to mid-stance, which is when we're about lined up in the middle of our body. In this phase, the hip's going to be in about neutral, and the knee is going to undergo relative extension to about 5 degrees. So never in this phase are we in a true extension or hyperextension, which will come into play later. Secondary to the progression of the tibia forward, our ankle is going to dorsiflex to approximately 5 and then later 10 degrees in this stage via eccentric plantar flexion control. The hip and knee extensors are active early in this phase, and the hip abductors help ensure stability of our pelvis, especially considering that our opposing limb is moving through swing phase. Next, we transition to terminal stance, and this is where we achieve a trail limb position. Secondary to this trail limb, it helps determine step length and helps determine how stable our body will be as we transition throughout the gait cycle. In this phase, the hip is going to move into an extended position to approximately 10 degrees. The knee is going to be slightly flexed, and the ankle is going to transition to neutral, and this is where we see the rise of our heel, which is very critical in setting up effective swing phase. Next, the passive movement that's achieved in pre-swing is really brought to because of the alignment in terminal stance. In this phase of gait, approximately 20 degrees of passive plantar flexion, 35 to 40 degrees of passive knee flexion are achieved, and the hip's going to move to a neutral position. Due to the extension of the great toe, we're going to have more stability in this phase, and also with the hip abductors. So if anyone just kind of wants to go through a couple steps so they can get a sense of what it feels like to move through stance phase, and really pay attention to what your body's doing as you transition throughout each stage. Next, we'll transition to initial swing, and this is when we're exiting the passive movement of pre-swing and entering active movement of swing phase. Active knee flexion from approximately 40 to 60 degrees is achieved in this phase. The hip's going to start in about a neutral position and flex to approximately 15 degrees because of activity of the hip flexors. The foot's going to begin to clear the floor. And sorry, I'm making you balance a lot, Lauren. But the ankle is going to remain in a slightly plantar flex position still. The anterior tibial muscles are on to help relatively dorsiflex the ankle, but we have not yet achieved a neutral ankle position. The maximum knee flexion that's achieved in the gait cycle is achieved during this phase. And if you like, you can just kind of practice transitioning from initial pre-swing to initial swing and getting a feel of how our body transitions through that phase. As we enter mid-swing, this is where our swing limb is going to be about in the middle of our body. This phase is really driven by achieving the maximum hip flexion and ankle dorsiflexion of this phase of gait and of swing phase. This is really driven by hip flexor and anterior tib control. The contralateral hip, as discussed previously, is going to help assist with stability in this phase as we're balancing on one leg. We're going to begin eccentric hamstring and concentric quad activity as our knee is going to start to begin to extend in preparation for initial contact. In terminal swing, we finalize our preparation for initial contact, and this is going to be achieved via increased knee extension. The ankle will remain in a neutral position, and the hip's going to remain in approximately 20 degrees of flexion. So if everyone wants to practice just going through swing phase a few times and getting a sense of what that feels like and how your body is moving throughout that phase. Okay, so this next figure is just going to focus on how the body progresses throughout stance phase. First, we achieve heel rocker, which occurs from our ankle transitioning from initial contact to loading response. Ankle rocker is achieved as our tibia moves forward and our body weight progresses forward. And our final phase is forefoot rocker, which is where we achieve the critical heel rise, which is needed for swing phase. Alrighty. Thank you everyone for your participation and for getting moving some. So next we're going to start with a broad overview of gait and MS, and we're going to narrow our scope as our discussion progresses. Many studies have shown that gait and MS is of decreased speed, and also individuals demonstrate increased time in double limb support. As a result of a multitude of factors resulting in gait dysfunction, gait is of decreased efficiency and also comes at a high energy cost. This has important implications because we know those with MS experience motor fatigue, which can further contribute to gait deterioration. High dual task costs, meaning difficulty doing two things at once, either from a motor standpoint or cognitive standpoint, is additionally noted. Ataxia or decreased coordination and impaired balance can be further drivers of increased time in double limb support. Also to consider, there's a multitude of MS symptoms that can have implications on gait. Numbness, tingling, and impaired sensation can result in difficulty of where our bodies are in space, especially as we transition throughout the gait cycle. And as you walk through, you can really see how many transitions are needed in the awareness of our body positioning. Dizziness and visual impairment can also be have further implications on gait. We know that our visual and vestibular symptoms are one of our three main systems of balance, and impairment of this can result in increased imbalance and further difficulty with gait. Pain can be present as a result of gait dysfunction or a multitude of orthopedic conditions, or as a result of a centralized pain mechanism related to MS. Muscle spasms, weakness, and fatigue can additionally negatively impact gait function. So given all of this, we're going to start to look, okay, I have a client in front of me. How should I start my assessment? Where should I build my thought process? Self-report measures are a really essential part of an evaluation. They're going to build a picture of what an individual looks like outside of a narrow 45-minute window or so that we may see them. An individual's self-perception of their function is important to understand their functional capacity. The 12-item MS walking scale is a self-report measure that's scaled out of 100 points. An individual rates their perception of their movement from not at all limited to extremely limited. This assessment is going to address fluidity of gait, the cognitive demand of gait, how far someone can walk, what assistive devices they may use, their balance, and their overall perceived gait limitation. Although the Modified Fatigue Impact Scale isn't a direct measure of gait with MS, it does help us better understand how fatigue may be limiting an individual's mobility. This 84-point scale has subscales that look at motor, cognitive, and psychosocial function. The Activities-Based Confidence Scale is a self-report measure out of 100% in which an individual rates themselves during typical daily activities from a scale of 0 to 100, and the scores are averaged. The focus of this assessment looks at both activities in the home and in the community and can have important implications on assistive device prescription if an individual has very low confidence when they're out in the community. The Dizziness Handicap Inventory is a self-report measure that is scaled out of 100. In MS, the cutoff score for fall risk is considered 59%. This test can be used to further identify how dizziness may be impacting an individual's daily function. When we're looking at an individual ambulating, there are several standardized measures that one can use. As discussed previously, impaired dual task is noted in gait in MS. As you can use the calculation that's shown on the slide to actually determine what percentage an individual is impaired in dual task, and you can use this with both cognitive or motor tasks. The 6-minute walk test helps simulate what an individual may look like while ambulating for a limited community distance. During this test, you really want to examine the role of fatigue when you begin to see signs of fatigue, how fatigue may impact things like turns or the need for rest breaks, and what assistive device an individual may use. Of note, this assessment is performed in a very closed environment, so this isn't going to replicate necessarily what someone will look like in the community. It just lets you know, can they make it that distance? For those who are unable to complete the 6-minute walk test, a 2-minute walk test is an accepted alternative if you want to be able to capture some type of gait distance. The Dynamic Gait Index has a cutoff score of 12 points out of 24 in MS, which is very different than the cutoff score you see in many other typical populations that utilize this balance assessment. This assessment helps us determine if there's an impairment in motor dual task conditions of gait, and it also helps capture some of the features of gait that are needed for community ambulation, such as visual scanning, stairs, and obstacle negotiation. So while you're doing these assessments, it's important to look not only how did they perform on the assessment, but what did they look like on the assessment. Foot drag or foot drop is a very common reason that an individual will show up in a therapy clinic. And my challenge for you is to really consider, is the problem only at the ankle if their foot is perceived to be dragging? Really consider the passive movement that's achieved towards terminal stance and achieving proper swing phase mechanics. Did we even achieve getting through this phase properly? If we're not in optimal alignment here, this can result in increased energy expenditure and increased dysfunction as we transition through swing phase. Also consider an initial swing, how we had to activate our hamstrings between 40 to 60 degrees with our hip in a near neutral position. Was the individual able to achieve this? Weak dorsiflexors are commonly seen in MS, but it's also important to consider whether weakness from the hip flexors or hamstrings could additionally be driving dysfunction in this stage. Also consider the role of the contralateral or stance limb in providing stability in swing phase. If this limb isn't providing sufficient stability, it can further contribute to decreased foot clearance in swing phase. Other common gait deviations seen in swing phase include stiff leg gait, and this often is someone who comes in and says, I just can't bend my leg. I'm trying so hard and my leg can't bend. And then as a result, you may see circumduction or a swinging of the leg as they advance through swing phase. Or on their stance limb, you may see them go into a plantar flex position to make their bodies relatively taller to allow that limb to swing through. In this instance, it really takes some detective work to figuring out why this could be happening. Some important considerations are the trail limb position and also what their body looks like in stance phase. If they're externally rotated throughout the entirety of stance phase, whether it be spasticity, range of motion, or proprioceptive deficits, it's unlikely that they're going to have a typical swing phase in this instance. One common gait deviation that you may see in stance is knee hyperextension. And really, as we discussed previously with the ankle and the foot drag, really consider, is the knee the only thing that's driving this issue? In typical gait, we should see about 5 degrees of knee flexion in mid-stance. Thus, any knee extension or knee hyperextension is seen to be atypical. It's important to look up and down the chain in this instance. During this phase, we typically see the hip in a neutral position and the ankle in about 5 degrees of dorsiflexion. Were these positions even achieved? Could an impairment in eccentric plantar flexion control be impairing one's ability to achieve dorsiflexion? What about spasticity, decreased control from the previous stage of gait, or proprioceptive deficit? And next, we're going to narrow our view a little further and discuss some. So we know they might have foot drop, foot drag, or a stance phase deficit. What are some of the specific causes? One of these can be impaired range of motion. So as we've discussed some throughout this talk, we do need about 5 to 10 degrees of dorsiflexion of our ankle as we progress through stance phase. Do we even have the motion available to do so? Are we able to achieve 10 degrees of hip extension, which is needed to achieve a trail limb position and set up for an efficient swing phase? If an individual is fixed in flexed lumbar extension, flexed lumbar flexion, or lumbar extension, it can impact the alignment up and down the chain. And even in your chairs, you can just move your back and see if you were stuck either here or there. It really does impact what your legs do when you're moving. As discussed earlier today, spasticity is commonly seen in those with MS. And we did discuss that the modified Ashworth scale is one assessment that you can use. But it's important to note that this assessment doesn't necessarily capture what an individual looks like in function. If you perform the test, it might seem like they have mild spasticity, but if you look at them in function, it can be a very different story. So don't only let a modified Ashworth scale score determine whether or not you think spasticity is mild or not. Spasticity of the quad, hamstring, ankle muscles, and toe flexors are very common to see. An individual may be unaware that they're having spasticity in their toe flexors, and if anyone wants to even get up and try walking on flexed toes, it's very challenging to progress throughout the gait cycle. Many individuals may be unaware that this is happening or won't report that this is happening when they come into the clinic. This is where removing an individual's shoes and looking at what their gait looks like both with shoes on and shoes off can be very essential in building a broader clinical picture. I also like to assess individuals at their typical speed and at a fast speed. So if they need to cross a crosswalk or cross the parking lot of the grocery store, to see how this may be impacting their function as well. Common areas of weakness of the lower extremities in MS include the hamstrings, hip flexors, and the core muscles and dorsiflexors. However, similar to the modified Ashworth scale in sitting, that's performed primarily in sitting, manual muscle testing that's primarily performed in sitting or supine doesn't build an effective picture of how an individual may be performing in function. As we started to discuss previously, you need to activate your hamstrings from 40 to 60 degrees with the hip in a near neutral position as we enter swing phase. Is an individual able to activate their muscles in this way? Strength while sitting and resisting someone here or in prone is very different than one's ability to activate and function. Motor fatigue can also negatively impact gait function. Important considerations are what time of day are you doing your assessment? An assessment that's performed at 9 a.m. may look drastically different than an assessment that's performed at 6 p.m. This is where your self-report measures really come in to build a more effective picture of what an individual may look like outside that narrow window that we're seeing them. Always make sure you ask an individual whether their fatigue level is like before you perform a gait assessment. Some individuals may say, this is an awful fatigue day for me, this is not normal, this is not typical, and this may lead you to think maybe I'm not really capturing what their normal is. Or on the flip side, you might want to look at them under a fatigue condition to really identify what's your limitation in gait in the community. Next, we put the puzzle pieces together. It's important to consider that there's typically more than one factor contributing to gait dysfunction in MS. This is where taking a top-down approach and analyzing what's happening at each stage of gait can be really essential, and really considering those first couple slides we looked at and what is normal and what is this individual presenting with. Next, you can put a hypothesis together and text it out in function. And it may take several follow-up visits and time to really understand why an individual is moving the way they are. So in regards to why this is important and preventing the risk for secondary impairment, we're going to use the figure up on the slide to build a clinical picture. I want you to consider someone with MS who might have weakness in their right leg. As a result of the weakness, when they go to stand, their right leg might be in front of them. As a result of weakness or spasticity or proprioceptive deficits, they may have increased time in double limb support and demonstrate a shortened step length. When they go to perform the stairs, they may perform a step 2 pattern or even use circumduction to help advance their leg. As a result, their ankle isn't achieving dorsiflexion in stance, and this can be a result of weakness or spasticity. Over time, if an individual is not utilizing this range of motion, it can further contribute to range of motion loss. As discussed in mid-stance, we need about 5 degrees of dorsiflexion. You can see this individual has an excessively plantar flexed foot. As a result of ground reaction forces, this is going to put excessive extension forces on the knee. We might see this initially present as a mild knee extension, but as an individual undergoes hundreds and thousands of repetitions of gait, this can lead to further and excessive knee extension beyond a typical or normal range. This can also present as excessive midfoot collapse for an individual who has poor shock absorption control when they transition from initial contact to loading response. In addition, atypical movement patterns can contribute to pain, and pain can result in further decreased mobility, and this can continue on as a cyclical pattern. On this slide, we're going to look a little broader of how this cyclical pattern can have important implications on an individual's function. If as a result of ineffective gait patterns, an individual experiences increased fatigue, they may not move around like they typically do. Unfortunately, for many individuals with MS, participation in typical daily activities, such as their ADLs and ADLs, may be their primary form of exercise, so to speak. If this is challenging to participate in, they may withdraw in their participation, and this can result in deconditioning. As a result of deconditioning, we can see secondary weakness and progress, and the cycle can continue to progress on if we don't do something to break the cycle. As therapists, it's our role to really see, can we break or reverse this cycle? If we address gait dysfunction through proper assessment, treatment, and recommendations, we can really optimize mobility, decrease secondary deconditioning, avoid secondary weakness, and improve an individual's overall fatigue and quality of life. Many impairments that were discussed previously can be improved through physical therapy, activity and lifestyle modification, proper assisted device and DME prescription, patient education, and proper medical follow-up. It's really our role as therapists to advocate for the potential for improvement in our clients. Next, Lauren's going to go through how we can break this cycle through proper assistive device and DME prescription.
Hold on, we gotta switch mics.
There you go.
All right. Can everyone hear me? Okay. So when we're talking about assistive device prescription, we have to think first and foremost, what is our goal? And it can be all of these, it can be ones outside of this list, but typically we're thinking fall risk reduction, fatigue management, decreasing pain, and ultimately community access and participation in meaningful activities. If we're gonna break the risk cycle like Jess talked about, we have to consider all of these factors because our clients with MS typically have very variable presentations and they might need many forms of equipment. When we think about what they need, we have to think about what is outside of the walls of our clinic. So what's outside of the wall in our physician clinic, what's outside of the wall of the acute care hospital, what's outside of the wall of our 45-minute therapy session, because ultimately what we give them matters in terms of access to do these things. So for those of you in the room who might be writing scripts for durable medical equipment, I hope that you walk away from today understanding that there's a lot of different factors that go into picking which device we do pick, and the important role that a therapist can play in determining the most appropriate piece of equipment. And for those therapists in the room who might be recommending equipment, I hope you consider different ways to look at it and thinking outside of the box for our clients. So when we look at unilateral devices, we're typically talking about a device that we're using for a minimal balance impairment, and we're typically talking about like a straight point cane or a trekking pole. I almost never recommend a quad cane. They're extremely heavy and they encourage you to kind of shift your weight over here, not use the more effective limb, so disuse weakness. And if you're shifted over here, when we talk about secondary complications, we're talking about back pain, range of motion limitations, and all those things. Now, if they're pressing a significant amount of weight through that device, that's the telltale sign that you should likely be considering more of a bilateral assistance. Now, I'll tell you, when you talk about transitioning from a unilateral device to a bilateral device, this is our clients kind of usually like hard stop. I do not want to use a walker. So we can use intermediate steps. With the intermediate steps, sometimes there's downside. So if we're talking about trekking poles, you can utilize one unilaterally and it really keeps you upright. You can utilize it bilaterally. It's great for our younger folks. It's a little more age appropriate, and you can use it in a more active environment or like a forearm crutch. But the downside to that is how the heck do you carry anything around unless you're carrying a satchel? So you have to kind of talk about what tasks do you need to do throughout the day, and is that the most appropriate thing to get those tasks done? So kind of the typical walker, right? If you look at all three of these, they look relatively the same. Aluminum frame, 2 front wheels, so does it really matter which one they get? The first thing we're always going to consider is how tall is the patient, how much do they weigh, do they need a bariatric, do they need a tall frame? But more importantly, where do they plan on utilizing the device? Are they going to use it in their home? Are they going to use it in their community? Are they going to use it just at work? What surface do they have? Do they have carpet? If they have carpet, you're going to want a larger wheel. Do they live somewhere where they have a gravel driveway? Can they walk to their mailbox to get the mail with this type of device? Do they have to transition over many different surfaces? If we start with the one on your right, or this side. These pictures aren't great, but so if you're looking right here, it has that push button lever to collapse it, right? So if you have limited hand function and you have to push down with one hand and use the other hand to collapse it, can you independently fold up your walker and put it in your car? Maybe not. If you look at the one in the middle, it has a lever system. So can I pull it up and close it all with one hand and then get it in my car independently? It's a lot easier to use the one in the middle. And both of them are covered by insurance. So you just have to actually see which one they can use. Now, if you're talking about someone with a lot of motor fatigue, but they need the stability of a front wheel walker, 4 wheels kind of is out of the question, you can look at getting a traditional aluminum style front wheel walker that has an optional foldable seat. Now, on the flip side, every time you add a bell or a whistle to a device, it increases the weight. So if you're going to increase the weight, can they still get it into their car? Now, Do we have the option to take our patients out by the valet, wait for their car to come around and practice all that? No. But can we set up something similar? Can you ask them to fold it up? Can you ask them to pick it up and put it over something? Absolutely. Or you could say, listen, we really didn't find the right device today. I really need you to go to therapy just for a few visits to try out some different devices so that we spend your healthcare dollars wisely. Because if you get them the one with the push button and they can't collapse it, insurance is not going to pay for the other one just because you didn't do your job. So we have to really think about that. And also, if you just send them with a script for DME, the person who's vending the equipment ultimately doesn't care about their function. Not that they don't care, but they're not assessing it. So we have to do our due diligence in making sure we're recommending the most appropriate type of equipment. Now, if we shift gears and we talk about kind of the Cadillacs of walkers, and this is where therapists get really nerdy because there's lots of ins and outs. When we look at the one on this side, that's kind of the typical rollator. It's covered by insurance. The advantage of utilizing something with four wheels is obviously it provides increased mobility. It provides options to carry things. If you do need to utilize a bilateral device, you can put something on the seat, you can put something in the basket, has the larger wheels, but the disadvantage is the decreased stability. So you have to make sure that they can navigate with this appropriately. Now you're gonna still consider hand function. So how does the brake system work? Is it really hard for them to lock it when they go to sit down? Can they get these in another vehicle because they're a lot heavier? How does it pull up? All those kind of things. Now, my biggest pet peeve with the first one is if you've ever seen someone, they walk like this with them, right? Because you can't take an effective stride length because the seat blocks your forward progression. So they come here. So they can still walk. But then they come in, 6 months later, my back is killing me. I have so much back pain now because they put so much stress on their low back. They get disuse weakness of their glutes because they never get that hip extension, and it's just a nasty cycle. So you can look at something like the middle version, which that seat folds up, so you can take a really great stride length, just like your traditional front wheel walker, but it has four wheels. And this one collapses inwards, so it's a little bit easier to get in and out. Or you can take a step up. Now, not all of these are covered by insurance. However, it's our job to show them what's out there, make a determination on what's the most appropriate, and then maybe they can get funding through outside sources, or they can afford to pay out of pocket for something like that. So the one on the far, that side.
Right.
That one allows you to stand up taller, and the seat actually slides back and forth, so you can get a bigger stride length with that. And the wheels are gigantic, so it's a lot easier to navigate. I have one client who's a professor on a college campus, so he needs that mobility to get around campus. Think of someone who maybe works in a construction site or lives in the short north and wants to get around the city. Something with a larger wheelbase is going to be a lot easier to utilize. Now, I'm going to show you one that I've never given anyone, but it's out there for the most appropriate client. These are kind of the all-terrain Rolls Royce of walkers. So they have what's called a climbing wheel. So you see this dual wheel on the front. One of them stays down while the other one raises up to get over curbs and thresholds. Again, someone who works on a construction site, someone who loves traveling, someone who loves to be outdoors, maybe they can't go the distance that they need to go, and they have the option to kind of sit down and rest, or just give them that stability when they're out there. These do come with a really, really hefty price tag, but I learned about them maybe, 6 months ago, and I thought they were really cool, so I wanted to talk to you about them. So shifting gears outside of just considering your assistive device, Jess alluded to kind of foot drop. So oftentimes I just hear, oh, you need an AFO. But our clients come in and they identify what's going on. I'm catching my toe. But if you ask them, they can't usually identify why they're catching their toe. They just know what's happening. They can't say, it's just I can't bend my knee, I'm just dragging my toe. So we need to evaluate what's going on, and we know that we need dorsiflexion, we know that we need knee flexion, and we know that we need hip flexion. But even if we can achieve all of those things, there's often the complicating factor of motor fatigue. So if we just write a script for an AFO and we send them to an orthotist, the orthotist is really, really good at making braces. But what they don't have the expertise in doing is evaluating what's going on. And they don't have the expertise to understand motor fatigue. So this is where we need to combine our physical therapy assessment with the skills of the orthotist to get the most appropriate thing. Now, almost all of our neuro rehab clinics have trials of different devices, so we can figure it out. But if we just put a brace on their foot and the issue is not their dorsiflexion, you just made their leg heavier. So it's going to be harder to walk. So let's look at a few different options for braces. And again, there's so many different ones out there, but I just want to kind of get the wheels turning. So if we look at the one over here, and this is not great, it's solid. So there's no hinge at the ankle joint, right? I want everyone to do something for me. Put your feet flat on the ground, and you cannot bend your ankle more than neutral. So you can't go into any dorsiflexion, right? So you're gonna be out here. Try and stand up. Right? If you're gonna actually achieve the task, what you're gonna do is you're gonna keep the foot that's braced out in front of you and slide your other one backward and use your strong leg to get up all the time, right? So you're effectively causing disuse weakness over time versus, and they're really heavy, versus putting them something with a hinged ankle joint. Now, the concern with a hinged ankle joint is if you just give them a hinge and you don't do anything, it's just flopping around, so there's no stability. So you can put a plantar flexion stop in there and limit how much plantar flexion they can get. You can put dorsiflexion assist. You can limit how much dorsiflexion they go into, so you can control all the factors while still allowing them more mobility. Now, the bumblebee brace, also you can do like an SMO, which will control for some of that calcaneal alignment and that midfoot alignment if they have any structural deformity of the foot, so we're not making that worse. You can ask the orthotist to make it with lighter weight materials. They can send it out to Cascade. They can do all these things so that we're considering how heavy is the device for someone who has potentially motor fatigue. Now, if you look at the anterior shell carbon fiber brace, that's a great option for some of our clients who maybe have some stance phase weakness. So their knee is trying to flex when they're trying to do weight acceptance. It provides a little bit of support for them to move forward over that brace with a little energy return from the carbon fiber. But the one I use most frequently is just the posterior upright, because most of our clients have weakness in swing phase. So you get a little bit of energy return from the carbon to assist with the little knee flexion and swing. It's a flexible forefoot, and it can be a really great option. Now, some insurances cover it and some insurances do not, but you can get it on Amazon. So just again, talking to your clients about what's out there, and trying some different things in different scenarios. Have them go up and down the stairs. Have them walk outside. See what works for them before you ask them to go and get a brace. So for those who might not need something so aggressive, there are other alternatives to AFOs. So you have a Swedish AFO that's just this white figure 8. It's not a great long-term solution, but it's like $30. So thinking maybe someone's in the acute care hospital, they had a relapse, and you're really, really concerned about fall risk, please don't get them, a custom AFO. when they're just getting out of the hospital. Talk to them about purchasing something out of pocket or trying to get some funding through the National MS Society or something, so that we can ultimately determine with some good rehab what is the most appropriate brace, because the carbon fiber ones are a heck of a lot more expensive to pay for out of pocket. Now, when you're looking at someone who maybe just has purely motor fatigue of the dorsiflexors, they're at work, they work downtown, they have no problem walking around their office environment, but they want to walk to lunch with their coworkers and they feel a little self-conscious because they do start to get that motor fatigue. Something like a foot up, which is the one that has a strap around the ankle and then it attaches to your shoelace, or a Sabo step, which you can put little holes in and attach. You can't really see it that well. It's kind of a little string, so it can be worn in lots of different types of footwear. They can just snap it on for the purpose of long distance walking and then unsnap it at work. Now the caveat is you really need to have good medial lateral stability of the ankle if you're going to go something as minimal as that. Now, someone who maybe it's motor fatigue in all three areas. Motor fatigue in the hip flexors, motor fatigue in the knee flexors. There's something called a hip flexion assist device. I always preface it by it's not attractive. It looks like two bungee cords going down the side of your leg. There's another version, it's called a Lima strap, that's more just along the front. But what that does is it assists you in picking up that leg but you have to have the strength to overcome the flexion moment for initial contact. It's not covered by insurance, but we get it funded through the National MS Society all the time. We have trials of them in our clinic. And when it works, and people really do like using the device. Another alternative that's probably the most expensive alternative is using electrical stimulation. So you can have electrical stimulation just for the dorsiflexors. You can have a thigh cuff that helps with knee extension. You can flip the device and stimulate knee flexion during swing, but it's thousands of dollars, and it's very hard to get it covered by insurance without multiple appeals if it's going to happen. So you also have to consider the urgency. So if someone is falling all the time, and they really want to try and get it funded, can they purchase something that's a short-term temporary solution and they can try and go through the appeal process? The biggest thing I caution you, because therapists, we want to try everything before we ask anyone to buy anything, right? I have a patient of mine who got a script not through MS clinic. I don't know if it was a primary care doctor or what. They went to the orthotist. They tried a Bioness. They were super excited about it, but they walk, 25 feet. It feels great, but if you watch her walk for 2 minutes with the Bioness, she can't. It's not because of the dorsiflexor. So she spent thousands of dollars when the device that we ultimately found out was the most appropriate was the hip flexion assist device. So again, it really does take a thorough assessment to figure out what's the most appropriate piece of equipment, especially when you're asking clients to come out of pocket to pay for these things. Now, I have to talk about alternate forms of mobility because sometimes the goals that the client wants to achieve, we have to consider energy expenditure and energy conservation strategies. So is it realistic to achieve all of these goals through ambulation? And we hope the answer is yes, but sometimes the answer is not all the time. If you're having a bad day, do you still want to be able to do X, Y, and Z? And if you're having a bad day, what are some options that are out there? Do they have a lot of heat sensitivity? What does access look like in their area? What is insurance coverage? And then how do we phrase these conversations? And I typically say it's a tool in the toolbox. And I'll never forget, I was talking to someone about using a rollator because their daughter was getting married and they were so concerned they weren't going to be able to set up the venue and be able to dance on the dance floor and do all that stuff. So we started talking about a rollator, options to sit down, and the conversation just took a turn, and it was, how long before I'm in a wheelchair? If I have to use a walker, how long before I'm in a wheelchair? And that's not what we're talking about. We're not saying if you get a wheelchair, you're never going to walk again. Or if you use a walker, you're automatically going to be in a wheelchair. It's what's the goal, and let's figure this out together so we can achieve the goal. And if you don't want to use it, that's your choice. But I want to make sure you have every option available to you. So wheelchairs, if Karina was still here, she'd get on her soapbox with me. But wheelchairs are really hard to figure out what device is most appropriate. And I have all too often been in clinic and someone comes in with a wheelchair that they just got and they weren't referred to a wheelchair seating clinic and there's nothing I can do about it. And they're typically in a standard manual chair where there's no adjustability of the wheel axle. They have a carpeted house. I mean, it's usually just a disaster. And fatigue is a major issue, and they start developing shoulder pain because it's not customized to them. So when we're talking about utilizing alternative forms of mobility, maybe it's just, hey, at the end of the day, if you're super tired, you know what's out there. Or you need to get around the airport, you want to get around the zoo. Using a standard manual chair is probably not the best solution. There are transport chairs out there, but typically if we're going down the route of a manual chair, we want to look at an ultra lightweight manual chair where you can adjust all the axles, you can have customized seating, but you can also have the option to add, if you look at the bottom picture, power assist. So it's a third wheel. It clips on the back side of the wheelchair, has Bluetooth technology. You start the push and the chair just takes off. Now you do have to have the ability to be able to steer the chair, otherwise it's a runaway ship, because there's no joystick. So you have to have that ability, but it's really great, especially if you have a young client who is in college and they want to get around college campus, and if they go to Ohio State, we all know how big that campus is, and you shouldn't be exhausted just trying to walk from point A to point B and then not have the energy to study later in the day. So kind of what is the big picture here? If we're not going kind of power assist, what options are there if you want to take your kids to the zoo, or you're traveling and you're just really concerned about having your own device, because we know that sometimes these aren't always available. You can obviously go to scooters or power chairs, but you have to consider how are they going to get it around. So if you go to a wheelchair seating clinic, that's something that they can sort out with the client. So hopefully you don't just write a script and they end up with a manual chair and then I'm really mad at you. So there's a lot of different things that we could talk about in terms of different devices that are out there to optimize function. But the take home I hope you get is our patients may need multiple pieces of equipment, and that's not wrong. And we have to customize that to what is the ultimate goal of our clients. We have to consider, what does their upper extremity function look like? What does their fatigue look like? Do they have the balance to be able to pick up the device and get it into their car so they can be independent? Do they have orthopedic considerations? If they have chronic back pain, should you be shifting away from a unilateral device more to something that keeps you midline? And then how do we talk about these devices? I always say tools in a toolbox, but you can talk about it in many different ways. And ultimately, education is key. We want to keep our clients active, engaged, and participating in life, and sometimes it just takes a little thinking outside of the box to get there. Thank you, guys.